as you know, as I mentioned, we are recording the audio version of our conference call. So when you ask questions, if you kindly only use your first name, so there's no identifying information on the audio. With permission of the speakers, the audio then is sent out to the participants, and we also post this information on the NFED YouTube channel. Again, that's with permission from our presenters. But we will let you know if that does happen. In fact, if the audio can be or will be sent on to or saved onto the NFED YouTube channel. So we have multiple speakers here tonight, and I wanted to welcome everyone and we thank you for participating in our first webinar of 2012 and our first formal webinar ever. I will do a short introduction of each of the speakers, and then I'm going to turn it over to one of our speakers. We have several individuals from Baylor College of Medicine in Houston, Texas. Am I right, Houston?
Go Blue.
Okay. We will have, first speaking tonight will be Dr. Reed Sutton, and he's an associate professor, Department of Molecular and Human Genetics. He's a clinical geneticist with special interest in Goltz Syndrome. We also have Dr. Igna Veyver, and she's a professor and vice chair of research at Baylor College of Medicine, and her studies led to the identification of the Goltz gene. We also have Dr. Richard Lewis, who is also at Baylor, and he is professor in departments of ophthalmology, pediatrics, medicine, and molecular and human genetics. Dr. Siegfried, are you on the call?
Yes, I am.
Okay, good. I didn't see your name, so thank you for joining us. Dr. Siegfried is at St. Louis University in St. Louis, Missouri, and she is the professor of pediatrics and dermatology. We have Dee Dee Olson, who is mother of Jade Olson, and today happens to be Miss Jade's birthday. She turned 11.
Oh, my goodness.
And
Happy birthday.
Jade is affected by Goltz syndrome. We also have a guest joining us tonight, and we have Dr. Robert Goltz on the line. Are you on the line, Dr. Goltz?
Yes, I am.
Wonderful. Thank you for joining us. Dr. Goltz, could you just tell us a brief sentence or two when you first saw your first patient affected by Goltz?
I'm sorry, say that again?
When did you first treat someone affected by Goltz syndrome?
Oh, well, 1962, I was at the University of Minnesota, and we had a patient in the hospital with this strange syndrome, and found 2 other cases in the community. So we had 3 cases of something that was apparently had not been clearly defined before, so naturally we wrote it up in the Archives of Dermatology. We chose the name Focal Dermal Hypoplasia, which obviously is inadequate to describe all of the mesodermal and ectodermal defects that can occur in the syndrome. But being dermatologists, we were interested primarily in the changes in the skin, and one of the remarkable things was the loss of connective tissue, so we called it Focal Dermal Hypoplasia. And that name is stuck because I don't think anybody's come up with a better name as yet, but obviously there could be a better name to describe the total ramifications of the syndrome. Okay.
Thank you for sharing with us tonight. And all of you, welcome, and we thank you for giving your time so that the participants on the line can hear the information that you have to share about Goltz syndrome. Dr. Sutton, I'm going to turn it over to you.
Great. So you're going to be moving the slides, I guess, right?
I will.
Okay, perfect. So it's a great honor to be on the call with Dr. Goltz, and he stole about the first 5 slides that I have, but we'll move right along to the next slide, please. Oh, back one, please.
Oh.
23, Kelly.
I don't know if I have a slow connection.
There you go.
So as Dr. Goltz just mentioned, so back in 1962, he really had the seminal publication on Goltz Syndrome, or Focal Dermal Hypoplasia, and gave it that name. It's also known as Goltz-Gorlin Syndrome because one of the dysmorphologists, who was actually by training a dental pathologist, Bob Gorlin, also described cases in 1963. Dr. Goltz went on to a distinguished career as chair of dermatology at Colorado, and then in the late 60s, I guess, and then back to University of Minnesota in the 70s as chair of dermatology. And it's thought that, although clearly Dr. Goltz identified this as a syndrome in a group of patients and named it, it's thought that the earliest report may actually be from a German who was working in Switzerland, Max Gessner, in 1921. Next slide, please. So Dr. Goltz's initial description that he had mentioned, although it certainly focused on the skin abnormalities that included areas of underdeveloped skin, and the medical term for that is hypoplasia or cutis aplasia, small spider-shaped blood vessels, the medical term for which is telangiectasias, streaks of dark and light patches on the skin in a linear formation, areas of fat deposits under the skin, and skin tags, particularly in and around the mouth, the genital and anal region, were reported. But it's very clear that Dr. Goltz also noted the asymmetry of the face, body, and extremities, as well as the developmental abnormalities of the hands and feet. Next slide, please. So I'm just going to now go through some pictures and discussing some of the skin and other manifestations of focal dermal hypoplasia. So on the right, you see a picture of a girl with focal dermal hypoplasia where the white arrow, is pointing to an area of underdeveloped or incompletely developed skin known as hypoplasia or cutis aplasia, and the black arrow kind of down around her waistline there is pointing to an area of fatty deposits. You can also see on her, as maybe better in other slides, this sort of linear, in her case, light-colored patches of skin there. Next slide, please. Other findings that, again, Dr. Goltz had reported in his initial publication included telangiectasias, which are spider-shaped blood vessels on the skin, seen here on this woman's cheek and denoted by the white arrow. Next slide, please. And in this girl of African-American ancestry, you can see these fairly linear light patches coming down her right arm that follow what are called lines of Blaschko, and those are known as hypopigmented areas. Next slide, please. Lines of Blaschko actually describe the pattern of migration that the skin cells take across the body during development, and this is just an illustration of lines of Blaschko on model figure. Next slide, please. With regard to treatment, the primary goal of treatment is focused on for the features that I'd mentioned just now, is in regards to the areas of cutis aplasia that can be treated with creams and patches to protect underdeveloped or eroded skin areas, as well as laser treatment for areas of the underdeveloped skin that may bleed, or for these spider-shaped blood vessels. Next slide, please. Abnormalities of the hands and feet are quite common in girls with focal dermal hypoplasia. And in this slide, you can see a girl who on her left hand has a split hand and absent finger on the left hand, denoted by the white arrow, known in medical terms as ectrodactyly. And on her left hand, which is on the right side of the screen, and the black arrow is noting fusion of the middle finger and ring finger, known as syndactyly. Next slide, please. Treatment of these sorts of abnormalities of the hands and feet is primarily surgical and with occupational therapy. Surgeons, if fingers are missing, or particularly if the thumb is missing, may move fingers around on one hand in order to improve the hand function. And again, occupational therapists work to develop strength, as well as providing adaptive devices in order to maximize hand function. Next slide, please. Again, as Dr. Goltz mentioned previously, so it is primarily skin manifestations that led to the initial description of Goltz syndrome, and part of the skin developmentally are the nails, and you see here on the left side of the slide girl's thumb that shows ridged thumbnail, and on the right side great toe that shows an underdeveloped and ridged toenail. Next slide, please. As I mentioned earlier, papillomas, or very tiny skin tags, occur in individuals with focal dermal hypoplasia, particularly as they age, not typically in young girls, but as they get older. And on the right, you can see examples of these rough growths that can occur on the lips, as well as inside the mouth and throat, in the genital area, and around the anus in girls with focal dermal hypoplasia. When present in the throat, they can actually cause problems with bleeding or swallowing. And around the mouth and in the genital and anal area, they may actually occasionally be mistaken by medical providers for sexually transmitted warts. Treatment of any of these papillomas or rough growths is with surgical removal or with laser therapy. And we do recommend that girls with focal dermal hypoplasia that are older have a letter from their specialist physician stating that they may have development of these oral mouth region or genital or anal region papillomas, so that other medical providers don't interpret them as a sign of they're having sexual intercourse or they're being sexual abused. Next slide. An interesting finding that's seen in focal dermal hypoplasia that is actually of no significance to a girl's health is a condition whose medical term is osteopathia striata that you see on the right. And on X-ray, you can see this kind of striped or ridged appearance to the bones, although, again, these don't cause any health problems or bone fractures or anything else. They're just an incidental finding of no significance to an individual's health. Next slide, please. Other occasional problems include problems with the development of the eye, either the eyes being small or there being incomplete development of the retina, the back part of the eye that the doctor or eye doctor takes a look at with the special light that he or she uses. There can be abnormalities of the kidneys or the urinary bladder, and it's recommended that girls with focal dermal hypoplasia have a kidney ultrasound. These problems are problems that are typically present at birth and not problems that develop at an older age. So those, both the eye examination and the ultrasound of the kidney that are recommended could really be done once, and if normal, do not need to be repeated. There can be problems with how the vertebrae, the bones in the spine, or the ribs develop, and that can sometimes lead to curvature of the spine as girls with focal dermal hypoplasia get older. And so it's recommended that an X-ray of the spine be done to look for abnormalities of the vertebrae, the bones of the spine, or the ribs. Again, this is something that would be present at birth. If it's not present at birth, no follow-up would be necessary. However, if it were present, this should be followed to ensure that girl with focal dermal hypoplasia does not develop a severe curvature of the spine. And then the last item on this slide, so the girls with focal dermal hypoplasia can have missing teeth or ridged teeth, and so regular dental care and orthodontic care in order to ensure an appropriate dental alignment for good dental health is important. Okay, next slide, please. And I think Dr. Veyver, who's coming on next, is going to cover most of this, so I'm going to skip through this quickly. It is on the X chromosome, and she'll talk more specifically about that gene. Women have two X chromosomes, while males have one X and one Y chromosome. In females, normal females, and in females with focal dermal hypoplasia, one of the two X chromosomes is turned off randomly to compensate for the fact that males only have one X chromosome. And so typically in males, focal dermal hypoplasia is lethal unless they're the first case in the family. And women who have focal dermal hypoplasia have 50%, if they have a daughter, it's a 50% chance of her also having focal dermal hypoplasia. A woman with focal dermal hypoplasia can have a healthy son, although she is at risk of having miscarriage if it were a male pregnancy that had focal dermal hypoplasia. And I think that's the last of my slides that should segue into Dr. Veyver's discussion of genetics and research.
Dr. Veyver, before you move on, I need to do one thing.
Okay. The conference is now in listen-only mode.
Thank you to everyone for being so quiet because that listen-only mode did not click on. So I do appreciate that. For all of you that are my presenters, if you should still be able to speak at this point. And you may begin. Is your first slide up? Dr. Veyver, can you hear me? Or are you speaking?
The conference is no longer in listen-only mode.
Okay. Well, that feature's not working. I apologize. But
So was I just speaking to myself?
You were speaking to yourself. They turned it off in you.
Okay, all right.
Apologies. We're going to leave that off, but I do ask for everyone, if you have any background noise, to be considerate of others, because that feature's not working. Or I
just lost my slides. Did anybody else lose their slides? Or?
No, I'm on. We're online. We're on up.
Okay.
Is yours on there, Mary?
No, but I'll reboot it. Go ahead. I'm sorry.
No, don't reboot. It's still working. You're okay. It'll come back on.
Start over again, Igna.
Okay, so I just want to give you a research update going back perhaps from how we ended up finding the gene for Goltz syndrome, and then some new updates from what we've been doing over the last 2-3 years in my lab, and put that a little bit in perspective of what I think are some of the key things that other people have done also on Focal Dermal Hypoplasia or Goltz syndrome. So we can go to the next slide. So
is this the correct slide?
On the genetics of FDH. So I started working several years back when I was a fellow on Focal Dermal Hypoplasia, together with a couple of other disorders, Goltz Syndrome and MLS syndrome, and we originally thought that these were all related, but I think that has then completely been disproven, actually. So, but when we started working on FDH, we kind of first started thinking about, okay, what is interesting and important about the features that may help us think where and how we should look for the gene. And so, as Reed already pointed out, it's quite rare, but what's important for us was the very highly variable severity, where some girls or women may have very mild features, and then some children have very severe features. What was also important and made research difficult initially is that there were very few known familial occurrences of focal dermal hypoplasia, and the disease is mostly sporadic. With the tools we had up to maybe the last couple of years, that makes it very difficult to find a gene, and that's why it's probably taken so long for us and others to find the gene. Again, it's mostly girls or women affected with FDH, but up to 10% or perhaps less could be men or boys. But what was never seen was father-son transmission. Like Reed said, all boys or males were first cases in their families, and what was very interesting is that mildly affected fathers could have very severely affected daughters, which really led very early on to this hypothesis that perhaps the gene might be on the X chromosome because of the way the disorder presents, and that the men with Goltz syndrome may have mosaic mutations, meaning there's a genetic change that only affects some cells or some parts of the body and not the majority of the parts of the body. And that's how, even though we talk about it as being male lethal, there's still some men with mild features of Goltz syndrome. So, and because of the severity, it was even before the gene was found, it was thought that it was subject to X inactivation, leading to this variable severity and also these mosaic findings, like Reed also explained about the lines of Blaschko. So the next slide. So we were actually doing technology called array CGH, where you just look for extra copies or missing copies of certain regions of the DNA, certain parts of the chromosomes. And we were doing this for two conditions, Goltz syndrome, for which we had many more samples, and we added on some DNA samples in the lab of girls affected with Goltz syndrome, and in a particular one, out of the first 4 or 5 or so that we tested, so we got quite lucky, I think, at that point, after many years of looking and not finding anything. And we found a missing piece of DNA on the X chromosome that contained 7 genes, of which one of them was PORCN. And this was just by far the most interesting candidate gene, and we immediately looked at it in the other samples. Right? And so, to make a long story short, when we started sequencing and doing DNA analysis, detailed DNA analysis of this gene PORCN, we found genetic changes or mutations that caused it to not be active in many of the other DNA samples that we had in the lab. And this is just an overview of where all the genetic changes and mutations are in Goltz syndrome. And as you can see, they're really all over the place in this gene. If you look at that slide, you see many of them where at the end of all these numbers, it's an X. That really is a stop coding, meaning it's really proved that the changes inactivate and cause loss of function of PORCN. On the bottom, those kind of pink-purple bars indicate that in addition to the majority of cases being caused by these smaller changes called point mutations, many of the, or a few of the cases that we and others have described have larger deletions or pieces of DNA missing that include PORCN. Next slide. So recently, I think a very nice overview paper from the Netherlands has been published, in the reference listed on that slide, that refers to a database at the University of Leiden that has been put on the web that everybody can access and look at. And right now, as of this paper and as of my review of the database yesterday, they've reported in the gene that there are 106 variants, means those are changes in the sequence, of which 80 are unique mutations that have been associated or identified in girls and some boys with FDH. So there's 68 sequence mutations and 12 large gene rearrangements, which are these big pieces of DNA missing. What's interesting, and what I'll get back to at the end, is that some of these changes now are found in other conditions that we know about, for which the etiology or the cause wasn't very well known. And one of them is the allergy of Cantrell, which is basically a defect of the anterior body wall around the heart, with sometimes the heart being on the outside, or an even more severe defect called Flint body wall complex anomaly, which is very severe, where the babies affected with this usually do not survive the pregnancy. And so what I have to point out is that this is usually in more complex presentations of these, and so it's still not very clear to have babies with just these things, without saying the problems on the hands and the feet that you can see in FDH, whether these could also be caused by PORCN mutations, and that's something we and others are very interested in looking at. Next slide. This is just a kind of a screenshot of this Leiden Open Variation Database, their PORCN site. And I think, for anybody interested, you can go there and look and follow the updates. But as you see, it's about, it's 106 still listed to date, so nothing has been added since the paper. I think there was some request to discuss, what's available for diagnosis and testing for FDH, and I kind of want to go back a little bit historically how we went about this, because this was quite a little bit of a challenge when we found a gene, because we know that people would be very interested in knowing when they participated in research or had their child enrolled in the research, what is going on in our family. But we wanted to do this right, and that caused, I think, for some perhaps a little bit more delay than they would have liked. But what we did is, even before we published the paper, we started talking to our medical genetics laboratories at Baylor, the MGL, to immediately transfer the information to the diagnostic lab. And so we now, and we verified every change that we found in our research lab through that lab before we actually informed the families that wanted to know and that we could still reach, because some people had participated in the research for many years and we weren't able to get in touch with everybody. This is a useful, on this slide that I'm showing here, is a useful resource on genetic testing that anybody can, it's the gene test site anybody can go to, and it lists the various labs, including the one at Baylor that currently offer genetic testing for FDH and where they are and some contact information. So I will go to the next slide to show you what is done at Baylor and how you can get there. What is listed as available is the sequence analysis, and there's two ways, and one is if there is somebody who may think that, they have Goltz Syndrome or Focal Dermal Hypoplasia or have a child with it, and the physician can go there and look up and then would order the diagnostic testing, which is just a survey of the entire gene sequence. However, there is also the target analysis, where if you already know in a family what the genetic change is, because there's somebody with focal dermal hypoplasia, then you can, if needed or desired, you can then just look for that particular change in other family members. This is usually the analysis that is done if somebody wants prenatal diagnosis to see if a person who carries the genetic change is pregnant, wants to know if the baby is or is not affected with the same genetic change. This requires some additional things, and usually some communication with the lab to make sure that all the quality control for the testing is done. This is our, actually, I wanted to just go back to that slide, if that's okay, because we don't have this listed, we don't have the deletion testing listed, but I just want to point out that I think the first tier is really the sequencing, and then if nothing is found, the PORCN gene is covered on an array test that's offered through Baylor and can also be done. Next slide. So what do we know about PORCN and where is the research? It's a very conserved gene, meaning it's present in humans and all animals, which points to quite an important role. And it codes for a protein that sits in a membrane within the cell called the endoplasmic reticulum, and it kind of goes across this membrane. And what it does, or what initially was known to be doing when we found the mutations in focal dermal hypoplasia, is that it adds a fatty acid. It adds a fat group to Wnt proteins. And Wnt proteins are very important in early development and as well as in the normal function of organs and tissues later on in life. And it's actually one of the major developmental group of factors. And these proteins are made in one cell, and then they have to be moved out of that cell, secreted out of that cell, to reach other cells that then respond to the signal they provide to that cell, and that activates downstream genes. So next slide. This is kind of shown here on this slide that may be a little bit complicated, but I can quickly walk you through it. The red sort of, and it's too bad I can't use a pointer, but you can see this red kind of thing under porcupine, which is the name that was given to this protein in Drosophila, or the fruit fly, adds this black thing to the Wnt, which is the fat group that allows the Wnt to go to the cells and then to other cells and activate the target genes. And next, I'll go to the next slide. So the research questions that we and others are working on to answer are a number of different things. And first, what we were very interested in is if this protein, this PORCN protein, does something to secrete Wnt proteins, well, maybe does it also secrete other proteins? Does it have other roles? And that's really still not very well known. But the question you have to ask then is, are all the features you see in focal dermal hypoplasia the result of defects in Wnt signaling? We think that the majority are, and we think that the majority are caused by a particular type of Wnt signaling through a molecule called beta-catenin, which is called also canonical Wnt signaling. So this is something I'll show you some information on that we're working on. And then the other important question we want to answer is, if we know more about what PORCN does, how can we perhaps use that information to prevent or treat some of the features of focal dermal hypoplasia? And as you've seen from what Reed presented, many of the things are there from early development and would be hard to come up with preventive measures, but some of the features like those papillomas on the lips and some of the skin features, they seem to progress during life, and perhaps if we understand how the protein works, we can do something about those and at least make these milder. And then we talked about already some other conditions perhaps, and then how does it function. So to do this, we needed a good model. And we can use mouse models, animal models, and cell culture assays. Next slide. And so there is actually something called a gene trap line, which is a mouse embryonic stem cell that you can actually buy from companies that make these, that inactivates PORCN. But these cells are all male, and so because of this very severe phenotype in males and lethality, with using those, we couldn't get many mice, and we actually only got one, which had some features that were interesting and looked like focal dermal hypoplasia, which provided the enthusiasm for us to start making our own model that would be a little bit easier to work with. Other groups, like the lab of Janet Rossin, have used these cells quite nicely in culture to look at some features of Wnt signaling that I'm not going to talk about now. Next slide. So we then made a mouse that has what we call a conditional PORCN mutation. And what that does is by the way you engineer this, you make it such that nothing happens to the gene when you have to breed and get the mice you want to analyze, but you can activate the change at a time and at a place where you want to do this. And so that allows us now to look at individual body parts, such as just the limbs or just the skin, or specific times in development separately, without having the very severe combination of different things. And this is a very powerful tool to now test the function of PORCN in an animal model, its role in disease and possible treatments. And I'm going to show you some data that are actually currently under review, and hopefully we have some good news that we may get our paper accepted soon, so we're looking forward to that. We inactivate PORCN completely very early on in development. What we know is that we can't get any male mouse embryos. And if you look at this picture here, on the female embryos, which have this change, this inactivation on one of their X chromosomes and not on the other, we get very severe defects. And the control is kind of what a normal mouse embryo looks like at about 9.5 days. A mouse pregnancy is only 21 days, so this is about halfway in development. And then on the picture under the TKO symbol, you see that this looks very different, and the brain is not developed normally, the body wall is not developed normally. You can't say much about the limbs on this, but I'll show you something about that on the next slide. We then also inactivate during limb development, and in the mesenchyme, which is kind of the precursor to mesodermal tissues. And as you can see, again, you see control, and then next to it you see PRX TKO, which is a PRX, that's a promoter or something that activates this gene to be disrupted. And you see that the limbs, this is just a bone preparation of the limbs of these mice, are very short, that all the bone structures are actually affected. The upper arm bones and the lower arm bones, it's on the forelimbs, and then on the hind limbs the same. What we didn't see with this was bony fusions or missing digits, but we do see this sometimes when we inactivate the gene a little bit differently, so it depends a little bit how you do this. We haven't completely analyzed the skull and the spine, but there's definitely evidence of some skeletal problems there as well. Next slide. We then also looked in the skin, and we used a keratin promoter, which is active in early development in the basal layers of the skin. And these are actually male mice, and you see that on the left here you have P7 control. That's a 7-day-old mouse that already has nice fur, and then the next to it you have this conditional knockout where there is most of the fur is missing. It's a little bit patchy, and this has nothing to do with mosaic like we've explained to you about Goltz Syndrome, but this is just to do with how well this promoter works. Under it, you can see that there are tooth abnormalities. On the left, you have the normal control, and then you see these mice next to it. They really don't have those nice two middle incisor teeth that the control mouse has. I just showed one of the many histology pictures, and it's gone now, but where you see on the left you see the hair, and on the right you see that the skin is very thin and there's no hair. We kind of looked at fat herniation. I'm not showing a picture, but the only thing we can see is that the fat's very close to the skin, and that's probably to the skin surface, and that's probably just because the skin itself hasn't developed well. So that question we haven't answered quite yet. Next slide. Here you see my conclusion. So we have a mouse model now that models the disease well. What we're starting to understand is that the role of PORCN in this Wnt signaling is much more complex than we thought, but we can now start to dissect that out, and we can now also use the mice or to test better treatments, and perhaps if we can activate Wnt signaling or beta-catenin, we can do something about that. Next slide. And these are the things. I'll go quickly through this slide because I realize I've talked a little bit longer than I planned. But these are some of the things we want to do, and we feel now that we can go back. Now we have the human features that are very important for us to keep thinking about. We can then compare that to the mouse, bring it back to help the disease in humans. We're starting a collaboration with Dr. Willis, who is a stem cell researcher who's very interested in making in going into this field, and I'm looking forward to that as well. Last two slides, I just want to point you to this resource if you don't already know about. In Gene Reviews, we wrote a review, Reed and I together, about Focal Dermal Hypoplasia, which I think is due for an update soon, but it's available as well. And I'm just have an acknowledgement slide of all the people that have helped on this project in the lab, collaborators, funding, and I think we would never have gotten this far without our initial funding from the NFED, and this really funding from organizations like yours is often the only thing that keeps us going on very rare conditions, because NIH may not have as much funds available to focus on those. And that's it.
Thank you very much, everyone, and it's an honor for us to be affiliated with all of you who give your time and your careers to this very unique group of conditions. As I mentioned earlier in the call, we have several speakers on the call. We also have Dr. Elaine Siegfried, and she would be happy to answer questions, as well as Dr. Lewis and Dee Olson, and then Dr. Sutton, Dr. Veyver. So, questions, we are open to questions. And you can either type your question in the chat portion, or you can speak up. There's an option to raise your hand, but feel free to just speak up, and we'll just politely take turns.
This is Elaine. I just wanted to know, I know the speakers are the healthcare professionals who are here. How many families or affected people are on the call? Because it's not listed on the website.
Right. I have 20 people on the call. We have about 15 families.
Great. Okay.
And that's quick math.
And I also want to thank both of the speakers for that excellent summary, and I want to underscore that, the gene reviews that are available online are detailed, but fairly much of a summary of what everyone just heard, and it's an incredible resource. So thank you also for doing the gene reviews.
Thank you.
Hi, I'm Dawn out in PA, and my daughter is 5, and she has Goltz and has major feeding issues, and I had emailed Dr. Goltz back and forth a couple of times. And my question for everybody on the phone, I don't really find that feeding is in all the research as issues for Goltz. Does anybody find that with their children as well?
What is the question?
How eating and feeding relates to Goltz syndrome.
Does your child eat orally or by feeding tube?
She's about 80% mouth, 20% feeding tube, but it just seems like when I read up research, there's not a whole lot that relates to the eating and feeding aspect of it, but it seems to be a common thread through a lot of the kids.
When you said feeding tube, do you mean through the nose and mouth, or do you mean through a G-tube in the
She has a G-tube in her belly since she's been about almost 2.
Okay.
So I can only make a comment from in a couple of the research mice. We have seen some problems with the intestines, but we haven't really analyzed that. I'm not surprised that there can be feeding difficulties because of where the gene is expressed and how it affects the lining of the body, which is the skin and also the mucosa. So Reed has a comment about that.
Other presenters have experience as well or information to add to Dawn's question?
I guess I would ask, this is Reed Sutton. So I guess although it sounds like your daughter would be very young to have these sorts of kind of polyps or skin tags inside the mouth or throat, if she's not been checked for that as part of her feeding problem, I think that would be an important thing to have an ear, nose, and throat surgeon take a look at.
She actually had her tonsils out and adenoids out, and her airway is clear. Her tongue is normal. We just find that she doesn't have the drive to eat. And also she has a lot of missing teeth, which adds to it. But just like the hunger, the drive is not there to eat.
I have a question, Goltz. In prenatal testing, do you use blood cells or biopsies or amniotic fluid cells? How do you test for prenatal diagnosis?
I have to say that I have not been yet personally involved with a prenatal diagnosis request here. But what we usually would do is we would usually do it for somebody who either has a family history where there is a chance that, maybe because of somebody else in the family carrying the gene defect, maybe another baby on the way with that. And then the thing we usually do is either a chorion villus sampling, an early test in the first trimester, or amniocentesis, where we draw fluid halfway in the pregnancy and then test for the genetic defect. The other reason would be if there would be findings on prenatal ultrasound that could be suggestive, and then do the gene.
Well, your printout will send us a list of centers who are willing to do this kind of prenatal testing.
Right.
Okay, thank you.
The gene review, the gene test site lists them.
Okay.
We do have a question that was typed in, a couple questions actually, so let me read those to you all. Someone says, having had a gastric bypass surgery, I've often wondered if vitamin absorption or lack of protein absorption could play a role in how the embryo and a human embryo develops. Is that a possibility, or is it always something that is genetically there at the time of conception?
So for Goltz, for
yes.
Focal Dermal Hypoplasia, it is always something there that at the time of conception. We don't know that there's any sort of nutritional or dietary influence on the manifestations of focal dermal hypoplasia.
No, and I think the work that you are doing at Veyver is clearly showing that it's due to the abnormalities in the X chromosome, which is be present long before any effect of vitamins or anything like that. So it's a genetic change exclusively, I believe. Correct me if I'm wrong.
Thank you. We have another question, and the person that typed that in, I'm not sure if I understand your question, so I'll just read it as I see it here. My daughter has a mild case. She is now 22, looking at treatment. Now has done a 3 treatment at UCSF. What is the average amount of treatment to reduce capillary retting?
For a dermatologist.
And I guess the question is, what treatment for what? Is it because of the skin lesions, or is it for something else, like the papillomas of the lips and the skin?
Treatment on the skin.
For the redness? For the redness?
Redness, yes.
Well, the skin.
So is it a pulse dye laser treatment?
Yes, that's what she's having.
So there's not a lot of comparison of how, lots of patients who've been treated, and so we can extrapolate information from other conditions. And so the pulse dye laser is used most commonly to treat other kinds of blood vessel birthmarks. And for other kinds of blood vessel birthmarks, it takes an average of 4 to 8 treatments that are typically done every couple months to get maximal lightening. It's harder to say for Goltz.
Well, there are a number of things that go wrong with the skin. Sometimes they have blisters, and those blisters may be broken, so they have to be treated as an open sore. Or sometimes it itches, and so we can have appropriate treatment for the itching. So
yes,
it's
doctor.
individual cases.
Yes, doctor. That's basically what's happening on her back side. We're getting quarter-sized lesions that are very sensitive to cold and blister and kind of are very uncomfortable. Yeah. Although she has a very mild case, considering most people on this phone have severe cases. We're just trying to get through the treatment. I know that it's not going to ever go away, but it's just we're trying to get through some times. With the gene, the different materials against her, rubbing on her skin.
And the other answer to the question is it's a little bit like painting a wall. You're done when you're done. And if it takes 6 treatments or 8 treatments, whatever, you have a target of maximizing the benefit and minimizing the number of applications.
So there will be there is a light at the end of the tunnel.
Oh, sure.
Okay.
Absolutely. There's always hope that things can be done. As far as other treatment, it obviously depends on if the bones are affected, maybe the orthopedic surgeons have to be involved, or if it's the kidneys, maybe it has to be the urologic surgeons. It all depends on the particular problem that you're dealing with.
Yeah. So I get some questions, and I know the families have more information, but we get some questions about treating allaying the red sore skin patches and fatty deposits so they become very irritated. What would you recommend families use for that?
Protection. Dressings.
I have some suggestions for specific products that may be helpful.
Yeah,
as a bland barrier. So
that's good.
And Dr. Goltz, it would be good to hear your comments on this too, but my favorites are just plain, preservative-free, 20% zinc oxide ointment because it's inexpensive and very safe. It's kind of messy, though. It's kind of messy. But the other one that's a new product is called Vaniply, V-A-N-I-P-L-Y. And that's clear, and that's a really low allergenicity, no irritation, mineral oil, petroleum jelly, dimethicone product. And you can
would you spell that again?
V like very, A-N like not, I, P like Paul, L like Y, Vaniply.
Okay.
And then there are also very nice dressings that can be applied to sensitive skin areas and left in place for many days. My favorite one is probably Duoderm Thin, D-U-O-D-E-R-M, because it's pretty easy to find, and it doesn't have adhesive. It doesn't have rubber-based adhesive.
Right.
Or cyanoacrylate-based adhesive, so that it'll stick on and it won't cause. It's got low potential to cause problems just from the adhesive. There are other dressings that are readily available, like Tegaderm.
Yeah, I'm familiar with it. Okay. I'm familiar.
Yeah, and Tegaderm is a pretty low-risk product also, and you can put it on and leave it on. It's clear. It's kind of like sticky saran wrap, but the adhesive in Tegaderm is kind of like a little bit related to crazy glue, so some people can get allergic to it, but it's really uncommon.
Great, thank you.
We have any other questions? I've let us run just a few minutes past since we did have some technical difficulties in the beginning. It got started a few minutes late. We have time for one more question, and then if there are questions that don't get answered, you can email them to the office, and I'll give you my email address, and perhaps we can ask our experts to assist us with those questions at their availability.
Absolutely.
My email, I'll give you that quickly, is kelley@nfed.org, and you can send the questions there. But we do have time for questions.
Dr. Lewis, what about any eye concerns? Is there anything specific about the eye?
Well, there are a lot of different features. Again, I think both Dr. Goltz and Dr. Sutton at the early portion of this emphasized the huge spectrum of variability of this condition, ranging all the way from normal eye development on both sides to, in some very rare reported cases, no detectable eye at all. And the most striking things are typically a small eye, often asymmetric, one eye maybe normal or near normal, and the other eye very small, and defects in the development of the eye so that there is a notch or defect in the closure of the globe as it forms embryologically, which leaves a little notch or defect like a little keyhole in the iris, which can affect not only the iris but the development of the retina and the optic nerve in the back of the eye. So there's a huge spectrum here, and unfortunately at this point there really is no effective, quote, therapy, end quote, to reverse the damage that's caused very early in eye development.
Right, that's what I wondered. Okay.
Thank you. And Dee Dee, what is...
Yes.
Are you there?
I'm here.
Okay, I thought so. What has been your philosophy from when you brought Jade home, and now that she's 11 and in her tween years? What has been your parenting philosophy, not only with Jade, but probably your other two children as well?
What has been my what, Kelly? I'm sorry?
Parenting philosophy. The questions that Jade may have about her condition, how do you handle those questions with her?
We've had tremendous success with Jade with just 100% acceptance. And I think our success has been that from day one, everything has been on the table. Everything has been discussed. She's been proud of her Goltz. She's been proud of her prosthetic eye. She's spoken at school and Boy Scout meetings and the NFED. Our involvement, it's given back so much to us as we've given to it because of the people that she's met and the comfort level that she's felt. When I meet new families, I always say, get involved as quickly as possible, and it just normalizes everything. And there's no secrets, no shame, no embarrassment. There's struggles, just as any affected or unaffected person may have struggles. It's just the way life is.
Thank you very much.
She's very confident. She's very confident in expressing herself.
Yes, she likes to think of herself as a spokesperson, and she knows that she's giving help and receiving a lot of help all at the same time.
Awesome.
So, and I just wanted to ask it sounds as though Dr. Veyver is finding, and I have to thank all the doctors for all of their time, effort, energies, all of that intellect being focused on this, and so many conclusions having been drawn. It sounds as though our children with Goltz will not have children with Goltz, or if they do have Goltz, that will be rectified relatively quickly. Am I correct in saying that?
I guess I'm not sure exactly where. I mean, we explained that people with Goltz, women can have a 50% chance adopting it well with variable severity, and then it's an individual decision within a family, some people like to do prenatal diagnosis and make decisions based on the information, and other people don't. One of the that I think is important, though, which we may not very much, is that there can be some variability. So if somebody features, their children could be health features if they have to change, or could be more severe, and the other way around. And that depends on a number of things like X inactivation or maybe some environmental factors. Some people think inactivation is the biggest variable, though. We have genetic testing available, and if that's what you're alluding to, yes, for sure. If we know what the genetic change is, which we can find in most people, although not in everybody, then we can look for that.
Yes,
is that the answer you were expecting? I wasn't sure what was.
Yes, no, I think I'm looking. I was looking for layman's terms to your findings, which some were over my head, and I felt that yes, that is the answer. That decisions can be made, and it sounds yes, you answered my question.
Okay.
Thank you. Do we currently know the number of people that are affected by Goltz, or do we have, or I should say, and do we have a breakdown of? I would guess the answer to male, female would be. You said earlier that mostly females are affected, and is less than 10% of males are affected. Is that correct?
That's the number I have from reading papers myself. Maybe Dr. Goltz has a better answer on that. I think it's a small percentage because it's so rare. Based on the papers that have been written, it's about 10%, but it could be less because there is a tendency, if something is unusual, to report it. So it may be a little bit of over-reporting of males compared to females.
Thank you. And we do have to cut our call to be respectful of all that have phoned in tonight to listen to these presentations and to learn more about Goltz. I thank you very much for participation. And if you have any questions, I sent my email address out, and I will do that again via our chat box. So that you have questions that were not answered tonight, we can get those answers for you.
May I say a word?
Yes, please.
I think we ought to acknowledge the contribution of the National Foundation for Ectodermal Dysplasia in supporting the research that Dr. Sutton and Dr. Veyver are doing. We owe them a debt of gratitude. And I'd like to also point out that the work that they're doing applies not only to the Focal Dermal Hypoplasia syndrome, but also to a number of other conditions, and even the development of the usual embryo. And that includes not only humans, but as they pointed out, mice and maybe other animals. And so it's extremely important work that they're doing with very widespread ramifications. And I think we have to be grateful to the parents and to the children who have this syndrome for cooperating so that this very important research can go forward. We owe them a debt of gratitude.
For those parents who are listening, I would add, as an expansion of that, we never understand normal first. We always try to understand abnormal and then figure out what normal means. And without the kind of dedication and cooperation that the families have contributed to these investigators as well as to others, these kinds of answers would never be solved.
Exactly.
Thank you so much, everyone. Those are very kind words, and I can tell you from the staff perspective, each one of us looks forward to the information that we can share with our families and the information that we can learn from all of the care providers. The NFED is just a great place to be.
You have a great organization, and I want to second Dr. Goltz's comments regarding that, because without the support of the families and your organization, we could not have done the initial phases of our research for sure. So, and it's very important to us. It also keeps us motivated, and I always make sure that people in my lab actually know what it means to have something like this in a family, and the enthusiasm you have for our research helps us going too.
Thank you very much for allowing us to participate.
And Dr. Goltz, it was a pleasure to have you on the call.
Absolutely.
Yes, thank you, Dr. Goltz.
Naturally, I'm very interested in the whole situation.
Thank you, Kelly.
Okay.
Thank you all very much. I hope you have a wonderful rest of your evening.